Greetings, nursing colleagues in India. I'm so honored and privileged to be able to present some of my experience to you as you embark on this first conference, and I wish you the best over the coming days. I hope that my words will be of good guidance to you, and I congratulate you as nurses on all the work that you do, especially at the bedside in saving babies' lives every day. So let's begin by talking a little bit about the alignment between quality improvement and nursing, because they are a pretty good fit as we think about what each one brings. And as just as a little placeholder here, I'll just let you know a little bit about Ariadne Labs. Ariadne Labs is in Boston, Massachusetts. It is a joint center for health systems innovation at Brigham and Women's Hospital and the Harvard Chan School of Public Health. Our vision is for health systems to deliver the best possible care for every patient, everywhere, every time. So I think in the goals of your conference and the goals of Ariadne Labs, we are aligned today. So let's think a little bit about nursing and the nursing process. Nurses, again, do a lot of the quality process as they take care of patients. We begin and think about the assessment of our patients when we walk into a room or when we take over care of that patient. We gather information. We begin to think about, is there a problem, or identify a nursing diagnosis? We think about planning. Do we need to set some goals? Do we need to develop a plan? Is everything as it should be? Or do we need to make a change, which means that we are then implementing? Do we take action to put the plan into place, especially as we identify a gap? We continue to evaluate, so we determine if the goals were met and if the desired outcome was achieved in our care of the patient. And we begin that all over again as our work continues with each baby in the neonatal unit or on the mother baby ward. We don't stop, we continuously gather that information. And so the same is really true about the quality process. Many of you I know have had some background knowledge and work around PDSAs, but I really want to think today about very small PDSAs, because that's really where your work can be highly impactful and successful, and you can learn a lot very quickly. So our goal in all of this is to build knowledge, building continual knowledge. And when we think about the quality process, again, we think about making a prediction. What is the problem? Is there a gap that we need to close? Do we do things the way that they should be done? Or do we gain new knowledge and our processes may not be the same as what we need to change? So thinking about that process, we begin to plan. We begin to set goals to close that gap when there is a knowledge gap or a care delivery gap. We develop a plan, how we can do it. How can we change this gap? We then look at the implementation phase, which is also doing. We take the action and we put the plan into place. As we do that, we begin to study that. So we're evaluating the process, we're studying it. Did everything go as intended? Were the goals met that we designed during the planning phase? Do we need to do this again, or do we need to keep moving forward and testing it under a variety of conditions? And again, we get back to that assessment where we start all over again. Do we gather enough information? Do we need to continue to gather information? How many times do we need to do this to make sure that things go as we want and not in the direction that we do not want them to go? So just to pause here, our goals are to build knowledge, to collect data over time, both quantitative and qualitative data, and to engage the right people. When we think about a new change that we want to make, we always want to start under the best of conditions. We want to start with one person, one time, one change. We want to start when the chance of failing is very small. In a hospital setting, that's usually on the day shift. We want to be able to make sure this works under the best of conditions. We want to definitely start with people who are willing to try something new. So you want to look for your close friends or colleagues or people that may already practice the way that you are looking to change the care overall. You want to start with the people that you have a trusting relationship with and who may already practice the new change. So let's think about this in terms of 135, 135, one person, one change. Then you can increase it to 3, then you can increase it to 5 people. Thinking small is not as easy as it seems. First, we're going to start with that prediction. Nurses are experts about care at the bedside. We know how the system works. We know how different people deliver care. We know that we are there for patients and for their babies. And so we know that we can often predict and have a lot of knowledge about a change and if it's going to succeed or fail. By taking this clinical knowledge and pairing it with the system knowledge, you can easily, as a nurse, make a prediction. So let's use a neonatal specific change. We'll use skin to skin as an example. If a newborn baby is put skin to skin on its mother, the neonate's temperature will be stable. That is our prediction. We're going to plan for that change. We are going to look at and define who, what, when, where, and how. Who will help us with this change? When will we do it? What will we do? Where will we do it? When will we do it? And how will we do it? So again, thinking about the skin to skin opportunity, we're going to also want to begin to plan to collect data. Did skin to skin happen? Data collection can be as simple as yes or no. Were you able to take the baby's temperature before and after and record that? Two really quick and easy ways to collect data. And again, focusing on the nurse leading the QI effort, the who, what, when, where, and how. One doctor, one nurse, one baby. We then enter into doing the change as planned with that one nurse, one patient, one doctor. What did we record? Did things go as planned? Were there any unintended um, uh, circumstances that you did not predict? We want to collect this observational data and move forward so that we can begin to assess if this change occurred and if it was positive. So now we're going to study it. We're going to say to the people that actually did the work, did this go as planned? Was it easy to do? Were there any things that you are concerned about? Did the baby's temperature change over time in the direction of positive? What events and what key points would you tell other people um, the next time that you're going to do this change? How would you guide them to do this? In other words, was it simple to do it? You could say to them, this was really easy. I was able to simply take the baby's temperature. The baby stayed with the mother for over an hour, and at the end, everybody was good. It was so much better than having to put the baby on a warmer, and much easier with no machinery involved if the machinery is even available. So this is where we really assess, can we move forward with this? And when we know that things went as planned, we can now begin to test it with more people and again keep building that knowledge over time. We now move to the let's try it with 3. It worked with 1, let's move to 3. Usually at that point, you also don't want to change too much. So what did we learn from starting very small? We started with 1, the risk of failure is extremely small, right? You're just working with that one mom, one baby, one doctor, and one nurse. You have an opportunity to collect immediate feedback from them. The change that you're building is very slow, but you want to go slow so you can go fast. At the end of this one process, you now have another nurse, another doctor who has tried the change that you're trying to change and will be able to talk to the next group of people to say, I was able to do that. It went easily. It did not cause any disruption. And I know that you can do it as well. So you are increasing your sphere of influence you're actually doubling it just by taking it to one other group. Rather than just a grouping of one, now you'll have that grouping of two. And again, you build that over time so that soon you'll have lots of people who have the knowledge of this new change and who can support you in this work. You've also collected data very easily. So testing the change in this chart can help you as you begin to think about what the change is and how you will test it over time. If you believe that the change, the cost of failure is very high, again, you know that you want to test very small because you want to collect as much knowledge as you can in a very small way over time. Because if something is going to go wrong, you want to know about it, correct it, and then change the way that you're going to do the work. I know in the real world, we often find out about new ideas and we want to take it and change the whole entire unit. But we know that we often fail with that. We cannot get everyone to do something. It takes a long time to build all of that will and knowledge across the unit. Instead, the next time that you want to make a change, think very small. Start with one, see what they tell you, then use them as the expert who has now done the change. And again, you will begin to build this in a much quicker way over time with a group who will support you in this change. Thank you so much. I wish you well in your journey and in your learning at this conference. And I hope that at some time in the future, we will be able to be in the same place and same time. Take care and thank you as nurses for all that you do.